But I want to thank everyone for coming to our session this morning or afternoon, wherever you may be in the country, depending. Yeah, the session today is Anti-Racist Social Care Research Methods in Action. And the presenters we have today are Janina Fariñas, April Joy Damian, and Francesca Williamson. They're going to be presenting their projects and research today, and they'll be going in that specific order. After, we will have a small Q&A session and discussion. I'm going to be the moderator, Benjamín Aceves. And I'm not sure if our discussant's here yet, but Lidia Regino is going to be our discussant if she's able to make it. And if not, we'll just have a great and rich Q&A discussion after. That's going to be a little bit longer. Just to kind of highlight some of the agreements that were initially discussed at the beginning of the conference, I think just some key reminders. Let's just respect each other's differences and backgrounds, and really be mindful of personality and power dynamics when we're having some of these discussions. And really, let's just try to use inclusive language and avoid using any derogatory, stigmatizing language as we're going through these sessions, and as we're asking questions and making discussions. And there's a few ways to engage, and you may have heard this already, but just to repeat, the discussion window is always open if we want to ask any questions, or if we want to save for the end of the presentation times. And also, if we want to have any reactions or anything, feel free to use the emojis. And also, when we are going to go into the Q&A session, we encourage you to maybe go on camera and unmute yourselves, of course, to go ahead and ask your questions, and raising your hand to get that attention. I can totally call on you, and you can ask your question directly to our presenters. And of course, don't forget about us on Twitter with the hashtag Siren Racial Equity, and then our handle Siren _ at UCS staff. So yeah, and we're gonna go ahead and start with Janina. I'm gonna go ahead and stop sharing.
Thank you. Good morning, everybody. It's a pleasure to be with you today. I'm Janina Fariñas. I'm gonna go ahead and start sharing my screen because I have a very short amount of time to share with you some very exciting information about our project, and to introduce myself and my colleague Andrea, who joins me today. So let's see here. Can everyone see that?
Yes, we see.
Yeah, all good?
Yes,
Thank you.
Good.
Awesome, thank you so much. So I want to introduce you to the work of Campeones de la Salud, which means health systems champions in Spanish. My name is Janina Fariñas, and I am the CEO and founder of a tandem organization, La Cocina L'Ancla. La Cocina is a community-based organization and nonprofit that provides no-cost mental health care services to our Latina community in Colorado. And L'Ancla is a partner to La Cocina, also a community-based organization that defines and designs actually equitable data collection methodologies, not only for La Cocina, but for other organizations and other dominant systems. So the work that I'm going to be introducing you to today, of course, is not just me. I have a whole team that supports this work with me at both L'Ancla and La Cocina, including Alejandra Magaña, Andrea Moreno Vázquez, who's here actually, William Joaquin, and Ana Raquel Gomez. So this work is focused on health literacy. The project is funded through the Office of Minority Health, with the lead as Eagle County government, the Eagle County Department of Public Health and the Environment. And even though I'm not going to go into health literacy into detail, it is important for me to mention that this project really resides in the spectrum of health literacy that is currently defined as critical health literacy. Reflective health literacy is another word that I've seen. And what I want to do mostly is show you some photographs of one particular aspect of this project, which is the sprint eventos de data, de colección de datos comunitarios. So these are basically, we call them in English, community data sprint events. They are sprint events in rural Colorado, so in 3 different counties in rural Colorado, and they're very specific to collecting data within the Latina community. Now, as soon as I say that, I'm sure many of you are wondering, what does that look like? How does that sound? And how are you doing that within the context, perhaps, of events, specifically events? So far, we have had 3 of these. That's what I'm going to focus this on. So what does it look like? It looks like a festival that celebrates family, community, and culture-affirming knowledge. And so what it actually is, it's a curated special event where we employ or deploy the concept of cultura cúrame, which is a very specific way of thinking about how culture actually has a healing impact on all of us. We refer to this as a community celebratory action research, so CCAR. Community celebratory action research, we recognize, is not on that spectrum yet, but since we're a community-based organization and not an academic department necessarily, one of the things that we thought would be really important to introduce here is how this community celebratory research really can have some very important impacts on the community as a whole. These are the activities that we conducted at each of these events, 3 in all. And these are our numbers at a glance. So at these 3 events, in the first one, we had 71 attendees, the second one, 171, and the third one, 140. People who registered for data activities, in the first one, 47, in the second one, 60, and in the third one, 46. Community health researchers were the primary folks who were collecting the data. Sometimes I was collecting data, depending on how many CHRs we had working in a particular event. And sometimes the rest of us were either collecting data or trying to mobilize the events forward. The collection of data consisted of these very specific activities, which really are community-based participatory action research activities that were designed specifically out of a series of about 60 ethnographic interviews that showed us some very important things. And so the focus of these events, we're looking at one of those most potent findings in the ethnographic interviews around what does it mean to have a sense of connection with one's healthcare provider or with the healthcare system. It was the #1 finding that we located within the ethnographic centers, or that we privileged within the ethnographic interviews, because community patients and community members repeatedly brought it up as something essential. So what is that? What are those actually connections? What does that connection look like? How do you break it? How do you repair it? In all, we have 991 data contacts as a result of those 3 events. And here are our preliminary results. Reciprocal communication is essential to advancing health literacy. And reciprocal communication has to be verbal in the terms of this particular community in rural Colorado mountains, conceptualized as reciprocal by both the patients and the providers. It has a positive influence on that spectrum of health literacy and promotes patient-led involvement. Respectful relationship has 2 primary components. The patient is elevated as expert in these relationships, and there has to be familismo, el toque de familia. That touch of family has to be there, including asking patients, how is your family? How is your daughter, for example? Feeling culturally affirmed is part of critical health literacy. The burden of change here, the key finding here is that the burden of change here is on the healthcare system. Cultural affirmation must not be limited to linguistic relevance. In fact, you could not necessarily have linguistic relevance, but still have cultural affirmation. And there's that toque de familia again. And direct participant feedback really meant that we want, as patients, to feel culturally affirmed. There's gratitude for being included in these events, gratitude to the CHRs who are listening to the stories and conducting the activities, and then feeling counted. Of these, feeling counted felt really essential. And an event where, if it feels like a festival, and we do not, by the way, collect any identifying data, so the consent form is very, very short at these activities, feeling counted felt like a really, really important part of the data that we weren't necessarily counting as an outcome in the beginning. Something else about CHRs is they increase the sense of community. this was also essential. So we ended up having approximately 27 CHRs at all 3 events. And one of the things that really was important is that the CHRs were from and community health researchers, right, form a community of practice that then moved around the events and were able to add value to how the activities were being conducted. All right, did I make it in 12 minutes? That's my presentation today, thank you.
You actually have some time left over. If we have any questions or comments, we can actually go into those right now. We have about 3 minutes.
Yes, and I apologize if that felt rushed. I wanted to make sure that I got in there some of the major pieces.
I totally understand. It's a little tricky sometimes, right? Do we have any questions or comments? I definitely have I have a ton of questions. I think this is such rich information. I think one of the things I had is in terms of data collection, and I know this is so research heavy, how did you all go about training yourselves within the communities and really understanding and taking that culturally informed approach to asking some of these questions? And, you know, whenever you're going into Latinx community, it's a very tricky situation sometimes because you don't want people, you need that trust, right? And so just wondering how y'all went about that.
Yeah, so that cultural curated piece is really essential to this particular data collection methodology because the events themselves were curated. For example, one of the things that Andrea, my colleague here today, actually spoke about in one of her presentations a couple of weeks ago was that our community impact manager, for example, spent a lot of time interviewing mariachis for the events. So we have mariachis at the event, we have DJs, we have children's activities, food, and everything is at no cost. Of course, it's like a festival. And you don't have to participate in any of the data collection activities to be part of the event. So the curated piece, right? The fact that our community impact manager spent a long time finding just the right mariachi, the mariachi from the community, the mariachi who's connected perhaps to the taco truck vendor, who's connected to the donut vendor, right? So the vendors become part of the event. It's a community. The event becomes a community. And so that curated piece is essential. It is the piece that I think most community members commented on because these are in rural Colorado. People said, we've never been part of anything like this. And we really appreciate the fact that this was a cultural event. And then they had the option within the event to participate in the activities or not. And the data collection activities were in a completely separate tent at every single event. So there's a separation there. And yet what we found is that we could never interview enough people. CHRs are very, very well trained. Our community health researchers participate in about 4 hours total of training. And that is very key to the success of something like this.
Oh, thank you so much, Janina. And yeah, that's so fascinating. I mean, a fiesta as an incentive, I think is fantastic. That I haven't really seen before, and I think it's great. Silvia Ann Reynoso, I don't know if you had a question. I know I saw your hand raised initially.
I didn't. I didn't know if I should just put it in the chat. Hi, I'm Silvia Reynoso. I'm from Texas, and we, you know, as you know, we have a very large Latino community. I do my studies, or I'm a researcher in sociology. I no longer teach anymore, so this is very interesting for me. And I just want to say thank you for finally coming and speaking. I love hearing about the Latino community. My question is, there in Colorado, I mean, here in Texas, we have such a diverse background of Latino communities. So there in Colorado, I'm supposing that you have the same effect as well. How do you converse, and how do you know what activities to involve when there's such an array of Latino backgrounds, and how does that work? And also another question too, if I may, gender. You know, coming from a Mexican community, men don't usually want to participate in a lot of things, and they usually don't want to participate in healthcare. How do you get them to do that, or do you see if they are even present while you're doing this research?
And so, not to interrupt Janina, but we have about 45 seconds, so
I'll be super quick. So incredibly relevant questions, Sylvia, and thank you for asking them. So in terms of gender, I think it really helps that we completely separate, right, the festival as a program activity, and then the data collection as something that is completely optional there. And so for men, they can just come, right? And they can be part of a family event. Making sure that the events are at a time and a place where the community usually meets is also essential. So ensuring, for example, that they're on a Saturday morning or a Sunday afternoon, for example, we had a Sunday afternoon one. And all of the decisions that we made, by the way, came directly out of about 60 ethnographic interviews that we had conducted in the community with Latina community members, right? Patients, Latina patients, and Latina healthcare providers or Latina serving healthcare providers. That is critical because that ethnography, that lived experience is what really allowed us to be able to co-design those events.
Thank you.
Thank you.
Okay, can you all see my screen? I see nodding heads, that's a good sign. And it's advancing. More nodding heads. Oh, wonderful. Okay, I'm getting the thumbs up. Well, good morning, good afternoon, good evening, wherever you are in the world. I'm so delighted to be with all of you. So I'm April Joy Damian, pronouns she and hers. I'm the Vice President Director of the Weitzman Institute, which is a research education policy center, has a national focus, but was founded within a large federally qualified health center, or FQHC, in Connecticut. So today I will be sharing with all of you findings from a recent research project we conducted that was funded by Aetna Foundation, which is, I now believe, is the CVS Aetna Foundation, looking at the health and health-related social needs of youth experiencing homelessness. And in this project, we used Photovoice as our methodology. So I'm a psychiatric epidemiologist by training, hail from San Francisco, where there's definitely a large homeless population, topic near and dear to my heart, because I also live in DC, nation's capital, which I believe has the highest prevalence of homelessness in the country per population. So this is just an overview of what I plan to go over in the next 12 minutes, and Benjamín will keep me honest. So first, giving a sense of how big of a problem this is, right? Youth homelessness as a public health challenge. So we know that it directly impacts over 4 million youth across the US, and that within that population of youth experiencing homelessness, there are some subpopulations that are disproportionately impacted, including Black and Latinx youth, LGBTQ+ youth, those who have not completed high school, as well as youth who are pregnant and or are parenting. And we also know that there's an intersectionality lens that is important to also take into account, that, you know, there also are LGBT youth of color, for example, so intersecting systems of oppression, which I'll get more into as I talk about our methodology. So greater risk, as you see, in terms of LGBT and African-American youth, with 120% and 83% higher risk, respectively, compared to their heterosexual, cisgender, and racial ethnic counterparts. We see that this is highly prevalent among young adults, and that at least 1 in 30 adolescents ages 13 to 17 will experience some form of homelessness over the course of a year. In all actuality, this is actually very hard to collect data on because of the current methods that are used to collect information about youth homelessness, but that is a separate topic and separate discussion for another time. When you think about homelessness, right, it's also important to think not just of the challenge of homelessness of itself, but also the web of other social or societal challenges and health challenges that those experiencing homelessness experience, right? From education disruptions to food insecurity, issues of safety, substance use, stress, and trauma, among others, as well as early death. So we sought before conducting this project, and even before proposing it, we sought the insights from trusted community leaders, right? So this work was conducted in Connecticut. Although I mentioned to all of you, I'm from San Francisco. Right now I'm in DC. Much of my project team was also not from Connecticut. And it was important for us to leverage the insights of two leaders you see here, Rob Dudley and Yvette Highsmith Francis, who have spent over 2 decades working in the community of New Britain. And so New Britain, Connecticut has a median household of about 46,000. There are 5 largest ethnic groups are there, with 1 out of 10 being non-US citizens, right? And they also noted New Britain's high school student population has one of the highest rates of absenteeism, dropouts, STIs, and teen pregnancy in the whole state. So in choosing Photovoice, I think, or in talking about Photovoice, I think it's important to get understanding of what is Photovoice, right? So really 3 areas that I want to highlight, right? It's a type of community-based participatory research where we essentially engage members of the community to partner with researchers, right? We often, we use oppressive language sometimes, or too often, I should say, in our research, right? Research subjects, research participants. We really wanted to level the playing field, whereas members of the community were essentially part of the research team and would then use their research as a catalyst for change, right? And so I'll go over the different methodologies that inform the theory of Photovoice. But the goals essentially of Photovoice are to allow people themselves from the community to record and reflect on the strengths and concerns of their community, and also to promote critical dialogue and knowledge through the use of photographs. And they do this in both large and small group discussions, as well as meeting with different policymakers. And so the 3 main theoretical underpinnings of Photovoice are critical consciousness, feminist theory, and documentary photography. So you'll note that none of these 3 come from healthcare or public health itself. These are all disciplines outside of our field, but how important it is to really draw from other disciplines and apply it in the context of healthcare and public health. So the first one, someone who really informed my early training in scholarship, or whose work I should say really informed my early training scholarship, was Paulo Freire, and really understanding how important it is for people to share their own lived experiences, have the platform, be at the table, to be able to then catalyze solutions and strategies for change, right? And so the connection to Photovoice is essentially getting people with lived experience to apply their lived experiences, have the space to talk about it, and then move policy or inform policy to affect change that is reflective of their lived experiences. The second underpinning is feminist theory, right? And essentially you can think about critical race theory, Lat crit theory, queer theory, these different theories wherein those who have historically and systematically not had power in certain spaces, or in different spaces, I say, now have the voice, are able to set the language and participate in decisions, right? And so in this case, we exclusively had recruited students of color and youth of color and LGBT youth, some of whom identified as being part of both communities, to really lead the discussion. And then last but not least is documentary photography, right? Really understanding that there are different ways in which voice and experience can be expressed, and what it means, the power of storytelling in the photos, right? Not necessarily the written language, but visuals to be able to share one story, right? And so this is really a summary of the concepts of Photovoice as laid out by Wang, right? Emphasizing both individual and community action and making sure that people from the community themselves can inform those programs and policies through their lived experience. And so these are the different stages, which I won't bore you about, but essentially you can see the patterns or how it, for those researchers in the room, how it is very similar in terms of qualitative research. And so for those, I know I want to be mindful of time, I want to refer you to our article published in the International Journal of Environmental Research and Public Health, where we essentially publish findings from this study. And the main takeaways or themes that we found was, one is the high relevance of mental health and trauma in this community, many overlapping social determinants of health. So not just experiencing food insecurity or transportation issues or safety, but maybe all of the above. And then the lack of social support systems. You'll note that we did not include, and I think it's important to note, the young people themselves as co-authors out of their own requests for their own safety and confidentiality, since they didn't want their identities disclosed to people or their homeless status being disclosed to people from their own community or at schools. And so we examined the individual, familial, and communal systemic factors contributing to youth homelessness through Photovoice. And as I said, really focusing on youth of color and LGBT youth. We couldn't have done this work alone. And I want to emphasize, it was really important to engage leaders in the community, not just the two I mentioned earlier, but also faith-based organizations, finding youth where they're at, homeless shelters, Boys and Girls Club, pride centers, really, essentially enlisted the support of 20 nonprofits as all of this work was done during the pandemic. And so I wanted to share at least a couple of narratives and photos taken by the youth. So this one is-
April, sorry
yes.
to interrupt, we have about 30 seconds left.
Okay, so this is an example of how they would show a photo and saying, become a better version of yourself. And this is all included in the article that I noted. So they take images and they were able to present it to each other and meet in person once it became safe to do so. And I just want to close with this in terms of the satisfaction, what it means for young people themselves to own the research, foster trust with researchers, and then build their capacity so that their skills can then translate, not just for research purposes, but hopefully become advocates in their own community in the future. Thank you.
Thank you so much, April. We're gonna go ahead and transition to Francesca. Thank you so much, and sorry about my internet going out. But Francesca, take it away.
Thank you so much. Good afternoon and good morning, everyone. I'm really excited to share some work that I've been working on for the last year with a group of collaborators. My name is Francesca Williamson. Most folks call me FW, and I'm a faculty member at a School of Medicine, a social science researcher, and methodologist. And I'm going to be talking about some work around how to repurpose old methodologies for anti-racist and health equity research. So just a brief overview of my presentation. I'm first going to share some research stories about racism, the relationship between language and interaction, and racism and racial healthcare equity. I'm going to introduce a methodology that I'm using for my work, and then I'm going to share an illustrative example of the ways that I apply this methodology for racial health equity work. So I'm going to start with just 3 stories from research that relate to language and healthcare equity. The first one is from some researchers who worked in cancer, doing cancer research with patients. They collected recordings of interactions and oncology appointments. And on the left side of the screen, you'll see a typical transcript of the kind of data that I work with. These are line-by-line turns of talk between doctors and patients. And in this case, the researchers were interested in patients' expressions of pain and how physicians responded. What they found was that patients rarely express complaints about pain, And they suggested that this might be because talking about pain and pain treatment is stigmatized within healthcare. But they also found that doctors only minimally acknowledge patients' expressions of pain. So on line 13 on this transcript, or in 12 and 13, you'll see that the patient shares that they experience pain in their leg, and the doctor only says, uh-huh. And that's all that they do. There's no empathy and there's no acknowledgement of that pain. And while the researchers weren't looking to make connections to racial healthcare equity in this work, it certainly has implications for racial health equity, because we know that when communities of color express pain and seek out pain treatment, their experiences of pain are often ignored or discredited. Another research story comes from a linguistic analysis of patient medical records. Another group of researchers analyzed over 9,000 patient records, and they found that clinicians most often use doubtful or judgmental words in Black and women patients' records. They suggested that Black patients may be subject to systematic bias in physicians' perceptions of their credibility. And this they considered a form of testimonial injustice. Now, these researchers were making explicit links between language use and systematic racial health inequities within clinical documentation, which they argue can also impact how other healthcare members interact with patients. And then finally, the third story relates to work that I'm doing in pediatric oncology. This is an old study from a sociologist who collected over 500 video recordings of pediatric appointments. And they were analyzing general practices in the ways that the physicians were communicating with children and their families. And what they found was that pediatricians were less likely to directly ask Black and Latino children questions about their health, in many ways positioning them as incompetent. And so while these researchers weren't looking to make connections to racial healthcare equity, their work does have implications for the various ways that children are systematically marginalized within healthcare and society at large. So the point of these stories is really that the way that physicians use language in healthcare systems matters, and it impacts the quality of patient care. And also, while much work on racism in healthcare has been focused on structural and broader policy type change, there's less work on the systematic interpersonal practices that create healthcare inequities. But the promise of the work that I do is that we can learn new language and new ways of communicating to promote healthcare equity. And this is important within the context of medical education, because interpersonal communication is a core competency developed through medical training, and it's an opportunity for intervening. So now I'm going to briefly introduce reflective interventionist conversation analysis. And I want to disclose that this methodology is part of a broader field of conversation analysis that came about through the field of sociology. And it was not originally designed or intended to be anti-racist or pursue health equity work. But that field has developed many resources and conceptual ideas that can support thinking about how misalignment or microaggressions, for example, might manifest in interactions. The specific approach that I use is called reflective interventionist conversation analysis. And this is a distinct approach that's more participatory. We engage with participants, including patients, physicians, researchers, and lots of different participants to think about how interactions and language use are unfolding in these clinical encounters. We're not specifically focused on deficits in interactions, but rather thinking about how do participants in healthcare work together to achieve healthcare. And one of the core assumptions in this work is that language is a primary medium for social action. So language isn't just words, we're actually doing something that can have social and material impacts on people in their day-to-day lives. And finally, one of the most important aspects of this work is not just studying and characterizing how racism unfolds, but then working to intervene with implications for practice. So I'm going to briefly provide an overview of a typical research process with this kind of methodology. We first engage with key participants in healthcare, this is patients, healthcare team members so that we can get their perspectives on some of the challenges related to communication and language. This is understanding, for example, how can you have a trusting interaction with your physician? What are the kinds of things that they say to you that make you feel supported and safe? And then from there, we develop a plan for data collection and analysis. And data collection can often take many, many months. 6 to 18 months is usually the range that we work with. And then we engage in collaborative analysis, whereas traditional methods for conversation analysis includes researchers with specialized skills who go away and conduct the analysis and publish it. We engage with our participants, again, these are patients, to get their perspectives on how providers are using language in ways that they think we could intervene to improve their care. And there are a lot of benefits and challenges with doing this work, but I think the benefits outweigh the challenges, primarily because I think through analyzing video recordings of patient experiences can illuminate new insights that we can't get from self-reported measures. And while those types of measures are really important, I think there are new ways of thinking about how racism unfolds that we see in other domains of life, such as police brutality. And I also think that this kind of work can inform data-driven policy and practice change. And some of the challenges relate to gaining access to data collection, the labor-intensive nature of collecting video recordings in clinical settings, and then from the clinician side of things, it can be tricky navigating the potential for identifying harmful practices. So we take a non-judgmental stance in this work and try to ally together to think about how to improve practice. And we also can't provide prescriptive solutions to the problems that arise in these encounters. So for example, we can't say, if you say exactly these words, you'll have this outcome. But instead we can help clinicians recognize how they're using language, the ways that they use language impacts the quality of the care that they provide. Now I'm briefly going to touch on how I'm applying this in a project on pediatric oncology, interactions with children of color and their families. Now, just by coincidence, I met a clinician scientist at St. Jude who was actually collecting recordings of interactions in pediatric oncology settings with children and their families from lots of different races and backgrounds. She was particularly interested in race and racism and how that impacts their care, but that was beyond the scope of her expertise. And at the same time, I was working on some work around trauma-sensitive communication as part of a broader trauma-informed care strategy to reduce the potential for re-traumatization for communities that experience racial, historical, and other kinds of trauma in health systems and more broadly. So we collaborated to conduct a secondary analysis of a subset of data, 97 audio recorded appointments with children of color and their families in pediatric and palliative care. And our goal was to think about how can we create trauma-sensitive communication based on the findings from these interactions. And then some of the preliminary insights, just to give you an example, the kinds of things that we find relate to children's rights to participate in their care, opportunities for empathy, often missed opportunities, and often these deficit-oriented questioning practices. And based on that, we're now designing specific trainings so that we can support clinicians in engaging children in their care, responding appropriately to emotional displays, and thinking about how they can ask questions that invite caregivers' expertise and empowerment. So the main takeaway from this work is that we need more insights into the subtle yet salient ways that medical racism manifests in systematic interpersonal practices. And communication and training are really important parts of the broader work needed to address racial health equity. I feel like I spoke really fast, but that is all that I have for you.
Thank you so much, Francesca. Really appreciate it. You're actually right on time, so thank you so much. Just transitioning really quick to Lidia Regino, who is with us today, and I just wanted to get some of your reactions, Lidia.
Overall or per session?
I think just some prevalent things you found, like how did you really reflect on some of the projects presented?
Well, the first project, it's awesome. Just the take on events as a way to do research in community events, taking into account language and culture and everything, and just separating it within. I've seen that actually works really well. In some of the work that I've done, people actually, when they respond to those kinds of ways of doing research, they kind of say things like, oh, I didn't even know that it was research, that we are so used to research or hearing about research in this way. And then when you do it this other way, we don't even know it's happening. And so we are contributing, but at the same time, we're also getting something out of it. And that's, I think that's an overall take on the three projects. It's really taking whatever the research is, but also implementing it in a community way so that the community takes something from the research right away, or that they hear and they get the information right away. Sometimes it takes years before someone hears what the outcome or the insight of the research is. So really going back to the community and talking to the community about what the findings were, or some quick findings. Sometimes you can get the total findings after the research happens. But so that's what I take on this. It's really taking language into account. It's huge. Taking into account the community that you're working with, and use.
I think really intersectionality was a big one in the work around homeless youth, and how impactful that is, right?
Taking people from within who you're working, or the research that you are doing, to actually work with the same group actually makes a lot of sense. And I saw that in every one of the three projects.
Thank you so much, Leah. I really appreciate your insight. And yeah, I'm super excited to take some of these findings and introduce it to our own work, right? Any other questions? We have about 5 minutes. We could probably take about 2 questions. Really want to prioritize Francesca and April Joy's work in asking questions, just because I know we had some questions asked earlier. So does anyone have any questions for the last 2 presentations? I know I have a few, so. Well, I'll start. Francesca, I noticed that you talked about doing some kind of interventions with some of the language being used. I'm just wondering, what does that look like? Are you really working with providers and people within the health system to identify words or moments where specific type of language and approaches should be used?
Yeah, so I actually use a role play method where we take excerpts from the data, we share it with participants, get their perspective on things that went wrong. And we don't tell that to the providers. We just do role play interactions with the providers to see if they recognize some of the things that might have gone wrong. And then we'll share with them, oh, these are some of the perspectives of the research participants. This might be how they were making sense of what you did in this interaction. So that's one way that we're doing that with medical students and residents and fellows.
Wow, that's so interesting. And I think it's really speaking to the need about how complex medical care can be. And April Joy, I just wanted to ask you if you could expand upon kind of that intersectionality piece, and how do you think that really impacted your research in any way? Because I think that's where we're pushing with a lot of racial equity, is really identifying where the intersections are and how those are very unique to research we're conducting. And how did you really approach that? And did that come up in your research, or is that something you already knew going into it?
Yeah, so it's something that I knew going into it because I've been trained in it. But it's also something that came from both the staff and the different organizations that I listed that we worked with, as well as the youth themselves, as we were trying to come up with, like, what are the questions we want to focus on. So in our own, we have a Ryan White program, and some of the providers have mentioned that even within, low-income LGBT population, that LGBT youth of color are not necessarily their experiences, for example, of racism, and then the project coincided with the murder of George Floyd, right? And just this increasing recognition, reckoning with racism in the country and in the world. And so that came up as we were preparing to pivot this work to virtual only, which was also interesting. But it also came up in the narratives. And I'm sorry to all of you that I had to rush through that piece. I should have better timed myself in practicing. But it also came up for some of them of saying, yes, like even if I go to this place that might be lavender friendly, for example, I may not be able to describe what it's like to be a Black man or Black male in New Britain, Connecticut, right? And to have that kind of lived experience. And then similar in terms of their youth who identify as part of the LGBT community, who are also maybe undocumented, right? And what does that mean in terms of legal status, as well as their own being able to fully embrace and be accepted in terms of their sexual orientation. So just recognizing how our systems need to change, that it's not just choose an identity and go here, but how can our systems be better suited to embrace overlapping identities?
Thank you so much for that. And I think that's so important. I think one of the things, I think in both April Joy's and Francesca's work that we're learning is these traditional safe spaces that have been seen as safe spaces for people to go to seek care, seek resources, really need to be more robust and more comprehensive in the things that they need to address. And I think everything from medical care to places like even like Latinx resource centers or Lavender resource centers really need to understand some of that intersection that plays into all of these needs. And I think that's what I hope everybody takes that away from this these presentations, is some of these places really need to be more robust in how they're meeting the needs of the community. And yeah, I'm wondering if anybody has any last questions or comments. We're at the last minute, so really want to thank our speakers and for really sharing the rich projects and data and information. And I think we all really appreciate you all coming today. But yeah, if we could give you a round of applause, we would, but I'm gonna definitely give you a round of applause and thank you all for attending today. Thank you, Lidia, for being our discussant today and really sharing some of your really insightful thoughts. And yeah, I believe there's another session, but yeah, we're gonna end there today and thank you all so much for coming.